Here are our objectives for today. Engage and inspire administrative, clinical, and quality leaders to adopt fall prevention best practices. Enhance current practices utilizing expert clinical knowledge to reduce preventable falls. Describe how to protect vulnerable populations from injurious falls. And identify the outcomes and clinical measures of fall program success, which preserve patient function, independence, health, and quality of life. Now, there's a lot of information you'll learn today, but here are the key takeaways we want to make sure that you learn. Utilize clinical expertise to define fall risk factors for specific clinical populations, including those in the emergency room. You'll learn the difference between at-risk and known faller patients, congestive heart failure, transient ischemic attack, and hip fracture. Realign patient outcomes from fall rates to the mitigation and elimination of fall risk factors for preventable falls. Apply the nursing process to evaluate individualized patient responses to care planning, and integrate best practices as common standards of practice.
I want you to commit today for tomorrow, to commit to the most important patient safety outcomes. And that's what we're emphasizing on this webinar as we move into clinical practice, is that the true clinical measures of fall prevention success are mitigating and eliminating fall prevention risk factors, but also for those that can't be eliminated or mitigated, to be able to help patients compensate for them and to align these to preventable falls. So we're moving you into precision. So we want to ensure that you are going to devote preservation of each patient's function, independence, health, and quality of life, just as Lillee had introduced to you. And what I wanted to do for you in this lecture, this webinar, is to focus on 3 populations that came into your ER, had a fall, or didn't have a fall, but presented to your ER, that cannot fall again in your care. They cannot fall again in your care. So congestive heart failure, transischemic attack, and hip fracture patients. And you can come up with your own populations after you've listened to this session, if you will, based on those who present to your ER. But you know what? There's evidence-based fall and fall injury prevention factors for each of these populations that you can pull together through convening clinical experts. But case studies are a wonderful way to help you to develop assessment, care plans, and prevention interventions based on fall risk factors per populations for which 2 types of falls? The 2 types of falls that are preventable: accidental falls and anticipated physiological falls. Remember, you can't look at all fall rates and know what you're doing is making a difference, because the interventions are specific to a type of fall. So that's why I love case studies. So I'm giving you a start on clinical case studies that I hope that you will take this as a learning opportunity and continue this educational process in your own organization. So let's start out with our congestive heart failure patients. Those congestive heart failure patients, you know the predisposing fall risk factors that they have. They have exercise intolerance, they've got respiratory symptom problems, they sometimes have reduced cognitive function. They may even have orthostasis problems because of medications that they have been on, some dependency in their activities of daily living, maybe even some impulsivity, thinking that they can do more than they really think that they can do, which is the same as safety impairedness, impaired safety awareness, overestimating their abilities. They may have some, if they have low oxygen levels, have some impaired problem solving, and even some incontinence that we could have with some of the symptoms that are going on. So when you think about congestive heart failure and the predisposing factors, I want to introduce you to your grandmother. So as I introduce you to our first case study, your grandmother has just turned 100 years of age, and yep, you know what? She's still smoking. She's cognitively alert, independent in activities of daily living. She walks with a cane that increases her stability. You know, she wears hip protectors because she's already had a hip fracture. And that happened when she was 92 years of age. And when that was when she was living at home. And after that, she moved into assisted living. So here she is now in assisted living. And I know for people that of this age, 90 and over, that the hardest thing that they can do is to stay independent. So she's been independent. She's on some her medical history is a little bit of, she has osteoporosis, coronary artery disease, irregular heart rate, a little bit of Lanoxin for that. as I mentioned, the hip fracture. She's no longer driving, and she enjoys a shot of whiskey at night before she goes to bed. So after dinner on a Monday evening, she was getting ready for bed, and she was sitting on the side of the bed, and she started to have increased difficulty breathing, coughing and wheezing, and she was feeling even more tired than she usually does. So what she did is she called 911 and she presents to the emergency department, your emergency department. Now remember, she's over the age of 100, and what makes her even more special is she's in the population age group where if they fall, they die. So you cannot let her fall in your care, in the ER or in acute care. So she presents to you in the ER with excessive fluid in her body tissues. As you can see, she's got edema, ankles and feet, her legs. She's coughing and wheezing. She's short of breath. She's had some weight gain with this edema, some fatigue, increased heart rate. Her appetite, she's been nauseated. She's had issues with that, and she's feeling confused and just disoriented.
So you've seen this. This is your patient.
So you do that assessment, and you do the lung sounds. You hear the wheezing and the coughing. You know the shortness of breath. As you can see, all that's on the slide, that she's got that edema.
So we know she is going to be admitted. We need to implement a care plan.
So what I have done for you here, based on the assessment and the risk factors that you know exist with people who have congestive heart failure, but for someone over the age of 85 who's 100 years of age, is that you have to develop a care plan after your assessment to reduce preventable falls. Remember, we're talking about preventable falls. So that means you have to create a safe environment. When you create a safe environment, you're reducing accidental falls. You have to develop an individualized population-based fall prevention care plan for someone who has congestive heart failure based on risk factors inherent to what you just assessed. And that reduces anticipated physiological falls.
So what I have prepared for you, colleagues, is a care plan that helps align the interventions to create a safe environment to accidental falls.
And the interventions to treat the risk factors inherent to your grandmother to reduce her risk for anticipated physiological falls. There's always an interaction effect between environment and the person, but you have to separate out the interventions because there are different types of falls. And that's how you develop an individualized care plan, but also based on the reason why she's at risk for falling, the congestive heart failure. You could apply this model to someone who's diabetic or other medical conditions, but I want you to see that this is aligning the interventions to the known risk factors in an environment for someone with congestive heart failure versus someone who has risk factors inherent to their person. So for someone who's over the age of 100, to create a safe environment, you got to look at bed placement. You got to put her bed closest to the doorway, any doorway in the ER where she can be seen by anybody who walks by, in the acute care setting, for anyone who's walking by her room. You've got to have a safe bed exit side, making sure that if she does have any kind of weakness, that if she gets up without you, she gets up towards her stronger side. You put her in a chair, you've got to put her in a high back chair. You just can't put her in a regular chair because she might slide out, especially if she leans forward for something. Use a bedside commode. Don't make her walk to the bathroom because she's going to be started on diuretics. So get that bedside commode. That is an intervention, creating a safe environment. Low bed position or stretcher position as much as you can. And what do you see there? A floor mat. You've got to have a floor mat to protect her from injury if she was to fall. But a low bed position is only going to reduce distance as they fall. Socks, these socks should be socks with shoes because she may have some foot drops, she may have some neuropathy, and you want to make sure that she's not in non-skid socks. But remember that O2 tubing? That's going to be a trip hazard. So all of those interventions that you see there on the left side of this slide are for those risk factors that are related to the environment of care, which is your responsibility to make safe when someone comes into your care. Now, to complement that, on the right side is the risk factors related to the congestive heart failure that we just assessed on the prior slide. You want to monitor her response to oxygen. You want to apply interventions that deal with energy conservation, maximizing her ability to function when she's feeling stronger or the oxygen level is higher, more appropriate. Completing small tasks rather than doing multiple long things at a period of time. Progressive moderate exercise, scheduled individualized toiling. You have to do that because she's going to be on diuretics, have some IVs going. So you have to set up an individualized toileting program. Medication monitoring. How is she responding to new medications that she's getting to treat her congestive heart failure? Making sure she has help with all her activities of daily living. and you know she's going to be anxious, and she may even have some sleep problems. So I hope that you see that this is truly for a high fall risk population lady, your grandmother who's over the age of 85, who's 100. You have got to protect her in a different way than just anyone who comes into your care that is fall risk, a high fall risk. This is population specific, age specific, and diagnostic specific. So I hope that this is helpful to you, because there is a clear distinction between screening and assessment for fall risk factors. The requirement for comprehensive multifactorial assessment is critical to individualized population-specific fall and fall injury prevention planning. So alignment of management to types of falls is so important, because the true measure of all this work is not whether or not they fell. It's improving their function and independence by mitigating and eliminating fall risk factors.
Thank you for watching this webinar preview. My name is Julie Cullen, the Managing Editor of American Nurse Journal. I invite you to watch the full version of this free on-demand webinar. Just follow the link in the description. You can also visit myamericannurse.com for a full collection of our free webinars. Thank you.